അപ്പൊ ഇനി പ്രശ്നം ഉണ്ടാവൂല അല്ലേ?
ഇനി എല്ലാ മീറ്റിങ്ങിനും നമുക്ക് തന്നെ ചെയ്യാൻ പറ്റും. കുഴപ്പമില്ല.
അതിപ്പോ
വന്നോ? ലൈവ് വന്നല്ലോ.
ലൈവ് തുടങ്ങിട്ടാ.
വന്നില്ല. നോട്ടിഫിക്കേഷൻ വന്നു.
ഇനി നിന്നെ ഹോസ്റ്റ് ആക്കിയാലും കുഴപ്പമില്ലല്ലോ.
എങ്ങനെയാലും കുഴപ്പമില്ല.
ഞാൻ തന്നെ നിക്കണമെന്ന്.
ഓപ്പി ഉണ്ടോ?
ഓപ്പിയല്ലേ, കുഴപ്പമൊന്നുമില്ല. എന്റെ കഴിഞ്ഞു.
ഞാനും കഴിഞ്ഞതാ, ഇറങ്ങാറായി. 4 മണിക്ക് ഇറങ്ങും.
അജീസ്
സാർ ഒന്നുമില്ലല്ലോ.
ഡോക്ടർ അജയ് കയറിയുണ്ടല്ലോ. എന്റെ ശരിയായിട്ടോ. എന്റെ ശരിയായി. ഞാൻ നബീലിന്റെ വെച്ച് ചെയ്തു. ഞാൻ അതാ ഫോൺ കട്ട് ചെയ്തു. ഇപ്പൊ യൂട്യൂബ് ലൈവ് പോകുന്നുണ്ടേ.
നബീൽ
ഹായ്.
ഹായ്. സ്മൈൽ. മാസ്ക് മാറ്റി ഒന്ന് സ്മൈൽ.
മാസ്ക് മാറ്റി. നമ്മൾ സ്പീക്കർ എത്തിയല്ലോ.
കുഴപ്പമില്ല. ഫോട്ടോസ്
യൂട്യൂബ് ലൈവ് പോകുന്നുണ്ടേ സർ.
ഓക്കെ.
ഡോക്ടർ റൌഫിനെ ഇതാക്കിയേ സ്ഥാപിക്കേ.
ഹോസ്റ്റ് ആക്കിണ്ടേ.
ഹോസ്റ്റ് ആക്കിയ നമ്മള് ഇത് ചെയ്യേണ്ടി വരുമോ?
ഹോസ്റ്റ് ആക്കിയിട്ടുണ്ട്.
ഓക്കെ. അഡ്മിറ്റ് ചെയ്യേണ്ടി വരില്ലല്ലോ?
വേണ്ട.
Good evening, Sabik.
Good evening. ഓപ്പിയിലാണല്ലേ?
Hello. Raga.
I think we can start in 2 or 3 minutes, right?
Nabil, shall we start now?
Hello. Can we
Nabil,
start?
We'll start. Okay. Good evening, everyone. So we are coming to the our second monthly IAP PG club. So today we have a good speaker, Dr. ABDUL RAUF KK. He's my colleague in Baby Memorial Hospital. He's a pediatric intensivist. So Dr. ABDUL RAUF has done his MD from PGI Chandigarh and done his FNB from Gangaram Hospital. And he's a very good academician. He has under around 20 publications in his name, and he has won the Young Talent Award by Indian Society of Critical Care Medicine. And he's very interested into teaching, mainly concerned with critical care aspects. So I'm sure that this will be a very useful section, useful talk for all of you. And he's in the industry of mainly ABG, shock, and about pediatric shock. And Dr. Rauf will be saying about few case scenarios and few tips on how to go about with each type of shocks. So over to you, Rauf. Please unmute yourself.
Okay. Thank you, Dr. Ajay. So, dear IAP office bearers and dear postgraduate students, a very good afternoon to one and all. So today we will be discussing about the management of pediatric shock with emphasis on practical tips and case scenarios. So the objective will be to discuss shock with respect to the pathophysiology, the types, recognition, So all these are very familiar to you, and our focus will be on management, which includes fluid therapy, supportive measures, inotrope, choosing the right one and the practical aspects, refractory shock, and I will touch upon newer advances including point of care ultrasound, and our discussion will be based upon few case scenarios. So the initial few slides I will be covering basic theory part, then the further management part will be discussed using different case scenarios. I won't hurry up. Dr. Nabil has told me that it's not time bound, so we can go slowly, and I will try to make it interactive. I will give you time to answer the question, and you can answer using the chat box. And finally, there will be some time for answering the queries also. So here we go. So the word shock literally means that it is a sudden upsetting or a surprising event or an experience. So when all of us encounter shock in clinical practice, all of us are literally shocked. So shock is life-threatening failure of adequate oxygen delivery to the tissues. So when there is decreased blood perfusion of the tissues, it leads to decreased endogen oxygenation, cellular dysfunction, and cell damage. Okay. So just note that hypotension is not included in the definition of shock. The shock is life-threatening failure of adequate oxygen delivery to tissues. So the physiology is, so shock is basically an imbalance between the oxygen demand of the body or oxygen demand of the tissue and oxygen delivered to the tissue. So imagine this is oxygen delivery, what we call as DO2. So from heart, that is from the lungs, the hemoglobin is loaded with oxygen, and the heart, the left ventricle, is pumping into the tissues. And just note here, there are 4 hemoglobin with oxygen, and the tissue normal oxygen extraction ratio is 25%. That means one oxygen from one hemoglobin is taken, and the rest go back. So this is a normal extraction ratio percent, and 75% go back to the body. Now, if you want me to tell one equation which is the most important in body physiology, I will tell. So this is that equation. So oxygen delivery to the tissue, it is governed by the cardiac output into oxygen content of the body. So oxygen content of the body is given by product of hemoglobin into saturation into 1.34 plus PaO2 into 0.003. So this is the dissolved oxygen content. So the heart is supplying oxygen to the tissues. So the oxygen delivered does depend upon cardiac output and oxygen content of the body. So all the basic management principles, the pathology behind the management principle, everything is based on this equation. Now, also oxygen delivery, we learned that it depends upon cardiac output and oxygen content. So as we all know, cardiac output depends upon stroke volume into heart rate. The stroke volume depends upon myocardial contractility, which depend upon the preload and the afterload. Okay, so the blood pressure also depend upon the systemic vascular resistance, and just we saw the oxygen content of the body depend upon hemoglobin and hemoglobin affinity, also the saturation and the PaO2. Now, if you want me to simplify it further to the extent that a layman can understand, you can just compare it with there is a reservoir of water, and the water is being drawn to a pump. The pump is hot. The pump is pumping it to our house tank. So the shock is when the water demand in the house is not met. That is what we call shock. So it can be because there is no water enough in the reservoir, that is decreased preload. When the pump is not working properly, that is the cardiogenic, what we call, or whether something is obstructing the outflow of the pump. Also, all these factors can result in shock. So just explaining the pathophysiology again. So when there is low intravascular volume or when there is hypotension, the baroreceptors get stimulated. So which stimulate the adrenergic reflexes, which result in tachycardia, result in the release of hormones like renin, steroids, epinephrine, and there will be vasoconstriction of the blood vessels in the non-essential organs. So body will try to restrict blood flow to the non-essential organ and shunt blood flow to the essential organs, which are brain and heart. So when the blood flow to non-essential organ decreases, that is when the blood flow to kidney decreases, that is what we detect as fall in urine output. When the blood flow to muscle and skin decreases in shock, that is what we detect as cold peripheries and prolonged CRT. Now, types of shock, all these are very familiar to all of you. So first is hypovolemic. It means that there is decreased preload, could be because of any volume loss like diarrhea, vomiting, burns, or a hemorrhagic due to blood loss. Second is cardiogenic. Our pump itself is not working properly, could be because of myocarditis or late phase of septic shock when there will be a cardiac dysfunction and arrhythmias. Third will be distributive shock, which includes septic shock, anaphylactic shock, and neurogenic shock. Distributive means there is a maldistribution of the blood volume. There is a venodilatation or there is a leakiness which is going on, which result ultimately in decreased preload. Now, fourth could be obstructive shock, which means that there is an outflow obstruction which is hampering the venous return or the cardiac contractility. So the classical examples are pneumothorax and cardiac tamponade. So just summarizing again, so the pathophysiology of shock is simple. Hypovolemia, hypovolemic shock, it leads to the decreased in preload, which result in decreased cardiac output. Now in septic shock, because of third space losses and leakiness, there is decreased preload, and per se it can result in myocardial depression, which result in decreased myocardial contractility. Both of them result in low cardiac output. In cardiogenic, pump itself is a defect which leads to decreased contractility and low cardiac output. Now, septic shock is unique because, so in all other shock, you notice that the cardiac output is getting decreased by one or the other mechanism. But in septic shock, in the initial phase, the cardiac output can be normal or hypercontractile. The cardiac output can be high, or on the late phase, it can be low. Okay, so hypotension and poor end organ perfusion can be there, but despite good skin perfusion. Why? Because the cardiac output is good and the vessels are dilated. Now, so this is the basic pals. Early recognition of shock is the most important part. So what we get in history is an history of loose stool, that is any history suggestive of any volume loss, any history suggestive of fever, that is suggesting infection, trauma, congenital heart disease, etc. So in examination, in neurological examination, a shocky child can be restless, can be anxious, agitated, and he can become comatose in the later phase. And there will be tachycardia. This is the sympathetic response. So the rough guide is in infants above 160, 2 to 5 years, above 140, 6 to 12, above 130, etc. Now blood pressure, we'll come to that. Now both central and peripheral pulses, they can be present or absent. So we need to look at the length of the pulse. So whether it is diminished pulse, normal, feeble pulse, bounding pulse, etc. And capillary refill time is prolonged. And obviously urine output decreases. So with all these clinical features, we can identify shock. So stages of shock, as we all know, there is a compensated phase, and when it decompensates, it goes for hypotensive shock. So in the compensated phase, there can be tachycardia, cold distal extremities, prolonged CRT, weak peripheral pulse, but the BP will be maintained with on the expense of vasoconstriction, which result in prolonged CRT. Now, once it goes to hypotensive shock, the mental status can get affected, output decreases, weak central pulse, and finally the deterioration in color, mottling, pale, cyanosis, all can happen, and hypotension happens. Now, these initial slides already mentioned. This all will be discussing the basics only. So the pulse. So what we determine by the pulse volume is it's related to the stroke volume of the heart and pulse pressure. So the narrow pulse pressure means it means that there is when the cardiac output has decreased or there is an increase in the systemic vascular resistance. So usually pulse pressure less than 25% of the systolic is what we call narrow pulse pressure. So this is one thing you have to remember. Now wide pulse pressure means there is a high cardiac output states and vessels are vasodilated. So wide pulse pressure definition is more than 50%. The pulse pressure more than 50% of the systolic blood pressure. So example BP 100/40. So the pulse pressure is 60, which is more than 50. So that is wide pulse pressure. So in a shocky child, if there is loss of central pulse, you have to be vigilant that it is an ominous sign. It is a child is going for cardiac arrest. You have to be careful. Now BP, the PALS definition of shock is based upon the systolic BP, but the most important for the body perfusion is actually the mean blood pressure, and it is a better indication for tissue perfusion, and it is not affected by the cuff size or the artery chosen. So definition of hypotension, you all know this. A newborn, it is less than 60 systolic BP, infants less than 70, 1 to 10 years, it will be 70 plus 2A, and bigger children less than 90 will be hypotension. So CRT again, they say it is a surrogate marker of the cardiac output or the stroke volume. So in cold shock, it's CRT will be prolonged, it's more than 3 seconds. In warm shock, CRT can be flash or brisk. Okay. So you examine the CRT in the extremities. You have to elevate the limb or elevate the extremity above the level of heart. You have to exclude environmental causes and then look at the CRT. So can we differentiate what type of shock clinically? So it's an important question. So how to identify hypovolemic shock? Obviously, there will be history of apparent loss of volume externally, be it diarrhea or trauma, blood loss, etc. And they have a narrow pulse pressure because body try to do vasoconstriction. So in distributive shock or the early phase of septic shock, there will be wide pulse pressure shock and disproportionate tachypnea and tachycardia. Cardiogenic shock, again, it is a vasoconstricted shock. There will be no apparent volume loss. With the child will be having severe tachycardia and features of pulmonary edema. So you know how to define septic shock. So this is again based upon the International Sepsis Conference Guidelines 2005 criteria. So septic shock means sepsis plus cardiovascular organ dysfunction. That is, so cardiovascular organ dysfunction is defined as, this is more of theory, I'm not going to the detail. So despite one bolus of 40 ml per kg in 1 hour, the child is having hypotension or need of a inotrope to maintain the blood pressure, or 2 of the following, which includes metabolic acidosis, arterial lactate more than 2 times, oliguria, prolonged CRT, core to peripheral temperature more than 3 degrees Celsius. So this is how septic shock is defined, pediatric septic shock is defined. Now in 2018, this is a definition has changed. That is called sepsis 3. So sepsis 3, now they define sepsis as life-threatening organ dysfunction, which is caused by a dysregulated host response to infection. So septic shock is a subset of sepsis with circulatory and metabolic dysfunction associated with higher risk of mortality. So there is a way to calculate this, which includes Q-SOFA score and all. But this sepsis 3 definition is till now not validated for children. So it is basically an adult definition. So you just need to know that there is something called sepsis 3. It can be asked in your exam for theory exams. That's why I just put this slide. Okay. Now here we complete the basic theory part. Now we'll be going to case scenarios, and we'll be discussing the management side by side with the case scenarios. So first I will put 3-4 cases, and this is just to identify what type of shock. So here we go. So 8-month-old boy was brought by his mother with a history of excessive crying, irritability, decreased urine output, and refusal of feeds. He had history of mild fever, cough in the preceding 2 days. He is immunized for age, no significant past history. So 8-month-old, excessive crying, irritability, non-specific complaint, and not feeding. So examination, tachycardia 196, tachypnea 70 respiratory rate, BP is 60/40. So here you should see it is narrow pulse pressure. Peripheries are cold, CRT is prolonged, peripheral pulse is absent, central pulse is weak, saturation on room air is only 70%. You do the systemic examination and find that there are bilateral basal crepitations, subcostal introing, heart sounds are muffled, and there is gallop rhythm, and there is soft hepatomegaly. You got the X-ray, and there is showing some cardiomegaly with features of pulmonary edema, and ECG is showing sinus tachycardia. So what is the physiological status of this child? So physiological status, this is based upon the PALS classification. So you can give your answer in the chat box. The answer I expect is there a shock? If yes, what type of shock, and how you classify it? Nabil, is the chat box settings open?
Yeah, everyone can chat. One says cardiogenic shock.
Okay, we're good.
Cardiogenic shock. Another option. Another one. So third answer also is cardiogenic.
Okay, so it is a pretty straightforward thing. So it is a hypotensive shock. So in PALS, you classify it as compensated shock or hypotensive shock. Okay, so it is a hypotensive shock, probably cardiogenic shock, and there is a respiratory distress also. It could be because of the cardiac issue per se, but the complete physiological status will be hypotensive shock, probably cardiogenic shock with respiratory distress. Okay, fine. Now we'll discuss about management of this case later. Now we'll go to the second case. So it is an 8-year-old child presented with history of fever for 5 days, cough for 4 days, and respiratory distress for 2 days. And while you assess the child, his airway was open and stable. Child had, it's an 8-year-old child. Child had tachypnea with increased respiratory effort and differential air entry. There was crackles. Child was hypoxemic. On oxygen improved to 95%. And 8-year child had severe tachycardia. CFT was brisk. BP was 68/30. Both central and peripheral pulse were very good, and the skin temperature was looking warm. And the child sensorium was preserved, and RBS was 59. So you also notice that child was febrile, and child had multiple pustules in his legs. So what is the physiological assessment? Please give your answers.
No answers here. Warm septic shock, one answer. Another answer, septic shock. Septic shock, compensated septic shock.
Yeah, so very good. So there was, it was a hypotensive shock now because BP was 60 something, it's 8-year-old. So hypotensive shock, warm shock, and there was respiratory complaints also. So to complete physiological assessment, there will be respiratory distress, and child was having hypotensive warm shock. Very good. So we move to the next example. So child was ingested metal coin. He presented with a massive bleeding from the esophagus. Examination, he was having cold extremities, tachycardia, heart rate of 180, BP 100/87. He was irritable, and we started resuscitation with IV fluids and blood products. And he was bleeding. We did endoscopy. He was bleeding, and he was bleeding from his mouth. We gave him multiple fluid boluses, etc. And he was shifted to operation theater. So what is your assessment?
Hypotensive. One answer is hypotensive.
Yeah, complete answer.
No other answers yet. Compensated hypovolemic shock.
Yeah, so very good. So very good. So it was basically a compensated shock, probably hypovolemic shock. Now we'll be discussing about management of all these cases later. Okay, fine. Now one more scenario. This is a case which all of you will be seeing very often in last few months. He was a 5-year-old child with acute febrile illness, presented with redness of conjunctiva, extremity edema. He had abdominal pain, loose stool, sterile pyuria, neutrophilic leukocytosis, lymphopenia, elevated CRP, ESR, acute kidney injury, and shock. And he had history of COVID positive 1 month. So it was pretty straightforward, multi-system inflammatory syndrome. So child was having cold peripheries and prolonged CRT. Heart rate was 130, BP was 66/32, saturation was 90%. So give your assessment.
One has answered PIMS, but I think we need the physiology, right?
Yeah. Obviously, it is multi-system inflammatory syndrome only. So I'm focused on the shock part here.
Hypotensive cardiogenic shock. One answer.
Yeah.
Hypotensive cardiogenic, hypotensive. So a lot of answers are.
Okay, so there was a cardiogenic complaints, right? The child had cardiomegaly, child had on echo, child had was having poor EF, but you should have noticed here the BP was 66/32. This was arterial BP. So this is one point I wanted to highlight here. So even it was a cold shock, cold periphery, obvious cold shock was there, but look at the BP 66/32. So there was a wide pulse pressure shock. Okay, so it means that there was cardiogenic, but there was an underlying vasoplegia. So this is a little confusing, and this is a higher level point which I want to highlight. So even if you assess the patient as cold peripheries and cold shock, but the patient, when you put an arterial BP and when you assess by echo, the patient can still have vasoplegia. Okay, so in the early phase of septic shock, the patient will be like what we discussed before, warm patient, high cardiac output status with flushed CRT, etc. But in later phase, what happens is the cardiac output starts falling. So the patient go for present as cold shock, but the vasoplegia part also will be there, which will be evident when you see the BP, especially when you see the arterial BP, or in the high level if you try to measure the systemic vascular resistance. So in this patient, BP was also 66/32. So it means that the patient was having both cardiogenic and vasoplegic shock. There was an element of vasoplegia. So in most of the multi-system inflammatory syndrome, what we have seen or what the literature has reported, predominant shock type is actually vasoplegia. There is a good number of children with myocarditis, but shock is usually vasoplegic, but some patient can have a cardiogenic component also. So I hope the point is clear. Okay. So this is a often debated, the clinical assessment of cold shock, warm shock cannot be accurate every time. Okay, so actually what you mean by cold shock is vasoconstricted shock or low cardiac output shock. In warm shock, what we tend to mean is that it is high cardiac output vasodilatory shock. But the septic vasodilatory shock, after it crosses a time, the cardiac dysfunction starts and they present with cold shock. So usually a patient, septic patient presenting with warm shock scenario happens usually in hospital shock only. For example, you have a patient, I'm trying to explain this point, a patient with leukemia who was neutropenic, he went to shock in your hospital, you detected it very fast, and that patient maybe you can get the features of typical warm septic shock what we explained. But imagine the same patient was at home, he presented with a septic shock. By the time child reaches in the hospital, what happens is by the time the cardiac decompensation would have started and child may present with cold shock. But once you put arterial BP and all, you find that there is an element of vasoplegia also. So there is so clinical correlation of warm shock and cold shock may not be accurate every time. I think, I hope I haven't confused you. I can clear in the end. Okay. So now we move to the management. So the management part will be based upon these two guidelines, Surviving Sepsis Campaign. The latest guideline was published in 2020, and ACCM guidelines, which was published in 2017, there are 2014 recommendations. So I wish all of you read this Surviving Sepsis Campaign 2020. This is the file may look very large and cumbersome, but you just go through this only the recommendation part alone. There are a few lines. It's very important, I feel. Okay. Now we'll go to the management part. Okay. So shock management. So I told you the shock is all about compromised oxygen delivery to the tissue. So the management will be obviously to correct oxygen, improve oxygen delivery to the tissue. So which will be increasing the tissue oxygen delivery. The other part will be decreasing the oxygen demand. So basically it's an imbalance between the demand and supply. So we improve the supply and we decrease the demand. Okay, so now look at the equation. So first step of starting or once you detect a shock, the first step will be start oxygen, high flow oxygen by non-rebreathing mark more than 6 liters. Why? Because in the formula you see, if you start oxygen, the SpO2 will improve and this PaO2 will improve. So even if your cardiac output is low, our oxygen delivery is going to improve. That is why we start oxygen is the first step of managing shock. Now secure a wide bore IV cannula. You can take the necessary samples. Now rule out, we'll be going to all these steps in detail. So rule out correctable causes like hypoglycemia, hypocalcemia, etc. Give the first dose of antibiotics. So the first dose of antibiotic should, if you suspect septic shock, should be given within 45 minutes. And it should be given ideally as soon as possible if after collecting the culture. But if you feel that collecting the blood culture might delay the initiation of antibiotic by more than 45 minutes, you can give antibiotics. Now fluid bolus. The next step will be fluid bolus. In hypovolemic or septic shock, we'll give 20 ml per kg. I will be discussing this in detail. In cardiogenic, we'll be very careful with the bolus and we'll be giving very small amount of bolus, and that too very slowly. And inotrope we are going to discuss in detail. Okay, so this is the ACCM guidelines. So we are discussing here. So first you recognize shock by decreased, based upon decreased mental status and decreased perfusion. So what do you mean by perfusion? So perfusion markers you divide to two. Okay, so perfusion markers are divided to two. One is the upstream perfusion markers and the second is the downstream markers. So by upstream markers we mean the markers which are related to the cardiac output, which include heart rate, blood pressure, CVP, cardiac output per se, etc. So these are upstream markers. So if I ask you to describe the hemodynamic status of a patient, first you will tell me about the upstream markers. How is the heart working? What is the heart rate, BP, CVP if available, cardiac output, etc. Now the downstream markers means what the tissue receives. So it is the tissue perfusion markers, which will include urine output, CRT, then what the quality of central pulse, peripheral pulse, then the laboratory markers will be lactate and SCVO2 if available. So all this will contribute to the downstream perfusion markers and all this will contribute to the upstream perfusion markers. So you recognize shock based upon this upstream and downstream perfusion markers and alteration in the mental status. So the first management, as I mentioned, will be start high flow oxygen. That will improve your oxygen delivery. Insert a IO or IV access. If you are finding it difficult to insert IV, you can go with the intraosseous access. Then next step is you start giving boluses. So we will come to that, how to give bolus and when to give. Side by side, when you put this IV cannula, you can take some sample CBC, you can do a venous blood gas or just to look for rapidly look at the electrolytes, look at the lactate, look at the bicarbonate, etc. and correct hypoglycemia and hypocalcemia if possible. So now we will come to fluid boluses. So first is which fluid to use. So always it is isotonic crystalloid fluid and NS, or nowadays there is a shift towards balanced solutions like RL or plasmolite. They may be better to give us boluses. That is the present evidence is coming up. So but just remember it's always crystalloid which is preserved. The rare situations where you can use colloids, otherwise it is always crystalloids. Now how much? So this is based upon the latest surviving sepsis guidelines. If the patient is hypotensive, you can give up to 20 to 60 and you have to stop when there is rails, that is when there is features of pulmonary edema, rails or hepatomegaly occur. So you can give up to, first bolus will be 20 ml per kg, slowly over 15 to 20 minutes. Then repeat. You can give up to 60 if you have an intensive care facility. That means you have to have a ventilation facility. Now, if the patient is hypotensive and if you don't have an intensive care facility or a ventilation facility, you can give only up to 40 ml per kg. So why? Because the higher number of boluses you give, there is now evidence coming up that you might land up in pulmonary edema, and you might need to intubate. So if you don't have good backup, I'm talking about septic shock, not hypovolemic shock. Hypovolemic shock, you can give boluses based upon the deficit, but in septic shock, don't exceed more than 40 ml per kg if you don't have intensive care facility. Now, we are talking about hypotensive. In compensated shock, give minimal bolus like 10 ml per kg or start maintenance fluid alone. Now, cardiogenic shock, already mentioned, boluses are slow, 5 to 10 ml per kg over 20 minutes. Now, how fast you can give bolus even in septic shock? So now the boluses should be over 15 to 20 minutes. So the earlier guidelines, say 5 years back or 10 years back, we used to discuss regarding push-pull technique and pushing the boluses over 5 minutes and all. So now what studies have found that if you give over 5 minutes, over 15 minutes, there won't be much difference in the endpoint of shock, but rapidly pushing fluid can result in increased chance of pulmonary edema and increased chance of ventilation. Even there are studies to suggest that. So that's why now the recommendations are you give bolus over 15 to 20 minutes only. Okay, so now fluid bolus part is clear. Now we move to inotropy. So inotropy, the students always have a confusion about inotropy, and the very 10 years back what people used to do is you start dopa, that is dopamine 20, then what you do, then start dobutamine 20 for every patient with shock, then what you do, then you start some norepinephrine, then you start preparing the death certificate. That was the story. So now the things have changed, things are more streamlined. We have bedside echo, we have arterial BPs and all. Now, so if you understand the basic pharmacology of each inotrope, starting an inotrope, it's not, trust me, it's not difficult. It's very easy matter. Okay, so you classify inotrope as predominant inotropes, vasopressors, and inodilators. So inotropy means something which increases the contractility of the heart or which increases the cardiac output, which include epinephrine, dopamine, dobutamine. Then vasopressors means which cause predominant vasoconstriction. They are norepinephrine and vasopressin. This is vasopressin. Now inodilators, which increases the contractility of the heart and also causes systemic vasodilatation, which will include milrinol, levosimendan, and even dobutamine has some inodilatory property. So we'll discuss in brief about the common inotrope. So epinephrine, so it stimulates all adrenergic receptors, alpha 1, beta 1, beta 2, beta 3. So it increases the contractility, it increases heart rate, increases systemic vascular resistance at higher doses. So increase stroke volume, cardiac output. Okay, so now the important point is that so epinephrine, the dose range will be from 0.1 mics per kg per minute, and you can go up to 0.3 mics per kg per minute. So below 0.1 mics per kg per minute, the predominant action of epinephrine is on beta receptors, that is beta 1 and beta 2. So that means it will cause inotropy plus vasodilatation. Okay, so that is why it is a very preferred agent in cold shock, because it increases your cardiac output and also relieve your vasoconstriction to a bit. Now more than 0.1, or if you go above 0.2, the epinephrine, the predominant action will be on alpha 1 and beta 1. So here there will be inotropy action, but there will be vasoconstriction action above 0.2. That is important about epinephrine. So it stimulates all adrenergic receptors, increases systolic BP and decreases diastolic BP at lower doses, at doses below 0.1. More than that, increases both BPs. Obviously, it increases the heart rate, causes tachycardia. So epinephrine increases systolic BP and decreases diastolic BP, maintains mean BP. So the dominant, when you increase the epinephrine concentration, the dominant receptor response will change from beta to alpha. I hope it's clear. Now coming to norepinephrine, it is a predominant pressor, that is, it is a predominantly causing vasoconstriction, predominantly act on alpha receptor alpha 1 and beta 1, does not have beta 2 action. So predominantly alpha 1 is vasoconstriction, beta 1 is some inotropic action. Okay, so It causes intense vasoconstriction and increase systemic vascular resistance. So increase both systolic and diastolic BP. So norepinephrine causes increase in both systolic and diastolic BP. So if you compare the catecholamines, so we discussed about epinephrine, we discussed about norepinephrine. Now dopamine nowadays it's not a preferred agent. Even in the cold shock, over the last 5 years, dopamine is not preferred as the first line agent. So because there is high chance of arrhythmias with dopamine. So dopamine, if you remember the pharmacology, it acts on D1 receptor, beta 1 receptor and alpha 1 receptor. So at dose of around 5 mics per kg per minute, the action is on D1 receptor. Around 10, the action will be on beta receptors, predominant inotropy. So if you go above 10 mics per kg per minute, in 15 to 20 mics per kg per minute, the action will be on alpha 1. That is, it is a predominant, it will act as a predominant pressor. Now dobutamine, it acts on predominantly on beta 1 and beta 2 receptor. It means that it has inotropic action, it increases the cardiac output, but it has beta 2 means it causes vasodilatation. It is a kind of inodilator. So vasopressin, nowadays we often use vasopressin. So we all know it is a hormone which is produced from the hypothalamic and from the pituitary. So it acts on different receptors. So predominantly the action what we use in shock is the V1 receptor action, where it causes intense vasoconstriction and it's a predominant pressor. Okay, it is a mild action on the myocardium, inotropic effect. It's very negligible. Now there are other actions also, V3 receptor action and V2 receptor action. But predominantly what we exploit in shock is the V1 receptor action of vasopressin. Now, the therapeutically, what are the advantages? So I'll just mention. So vasopressin as a catecholamine sparing effect. So vasopressin is not used as a first line agent in any kind of shock, even in vasodilatory shock. So we start with norepinephrine only. So norepinephrine, if you start increasing the dose, and if you reach a dose of around 0.2, if you increase norepinephrine beyond that, there will be increased myocardial oxygen demand. So from this point, you can start using vasopressin. So if you start vasopressin, there will be a catecholamine sparing effect, means you will be able to gradually come down on the norepinephrine dose, or you won't need to further hike up the norepinephrine dose. So that is the beauty of vasopressin. It has catecholamine sparing effect and it does not increase the myocardial oxygen demand. So both epinephrine and norepinephrine has action on beta 1. It might increase the myocardial oxygen demand. Vasopressin does not cause that. However, it is not a first line agent. It is always after norepinephrine as a supplementary agent till now. Now this is a novel drug, Levosimendan. I don't know how many of you have used it. So again, this is an inodilator. Its basic mechanism is called calcium sensitization. It does not increase the intracellular concentration of free calcium. The beauty of this drug is that Levosimendan, it is used in cardiogenic shock. It has a very prolonged half-life. That is, if you use it for 48 hours and stop, it stays in your body for 7 days. So this can be double-edged. So in a cardiogenic shock, if your BP is very good enough, so Levosimendan, again, inodilator means increased cardiac output causes vasodilatation. So you can start inodilator only if your BP is very good. If BP is reasonably good. Otherwise, if you start inodilator, what will happen? There will be hypotension. So you can give in a cardiogenic shock, a patient who is stabilized with a good BP, you can use Levosimendan, stop it after 2 days, and the effect, the inotropic effect will be sustained for next 7 days. Okay, now again, I'm coming to the practical point. So inotrope infusion preparation, how to prepare inotrope. So this is the most important part you should know. So coming to adrenaline, noradrenaline, so the dose range is adrenaline is 0.1 to 0.3, norad 0.1 to 0.3 milliliter, non is 0.1 to 1 mics per kg per minute. So how to prepare? So you mix weight into 0.15 milligram. For example, if the weight is 10 kg, you mix 1.5 milligram in 25 ml NS and set it 1 to 3 ml per hour. So if you mix in this dilution and set it 1 ml per hour, so the 1 ml per hour will be equal to 0.1 mics per kg per minute. So why you need to standardize this? Because you start inotropy in your shift and you go after the night duty. Tomorrow morning, the next resident come, and once he sees that the inotrope adrenaline is at 1 ml per hour, he should understand that 1 ml is 0.1 mics per kg per minute. Okay, if you set at your own rate, then it will be very confusing for the other persons and nurses to handle. So that is why you should have a standardization. It is pretty simple. You can by heart it. Just you encounter 10 kg child, so you can just tell start system for 1.5 milligram adrenaline 25 ml, start at 1 ml per hour will be 0.1 mics. Okay. So even this you can start at 0.5 also, that means 0.05 mics per kg per hour also. Now coming to dopamine and dobutamine, so the dose range is 5 to 20 microgram per kg per minute. So how to prepare? Weight into 15 milligram in 25 ml NS and set at 0.5 to 2 ml per hour. So 0.5 ml per hour will be 5 mics per kg per minute. For vasopressin, the dose range is 0.003 to 0.0012 IU per kg per minute. So how to prepare it? Weight into 0.45 IU in 25 ml NS and set it 1 to 4 ml per hour. 1 ml will be 0.0003 IU per kg per minute. So you can take a snapshot of this slide. This is very important. And you can use this practically so that there should be a inotropy in your unit. So 1 ml will be 0.1. There is no confusion with it. So this dilution, what I meant is for central venous lines. So we'll come to peripheral. I will come to the dilution, what we should be doing when we are using peripheral line. This concentration is meant for central lines. Now, how to choose the right inotrope? If I want to give a simple algorithm, that will be like this. For example, a septic, we have discussed about the basic pharmacology of the inotropy. So you're dealing with a septic shock patient, cold shock. So cold shock, just remember, it means that the cardiac output is low, patient is vasoconstricted, or probably vasoconstricted. So cold shock, the first inotrope will be epinephrine. So dopamine is out now. Epinephrine, you start at dose 0.05 to 0.1. So we know that in 0.1 dose, what epinephrine will do? It will increase the cardiac output and it will cause some vasodilatation. So and it will help in the resolution of cold shock. Now you start epinephrine and patient was still hypotensive. You increase the dose of epinephrine. Then the next will be you add norepinephrine or vasopressin. Okay. And if you find that the BP has improved, but the perfusion is compromised, it means that BP is very good, but perfusion in form of CRT, in form of urine output, in form of the pulse quality is less. Then later, if the BP is very good, then you can add this inodilators. So BP improved, perfusion compromise means that your cardiac output is still low, but you have vasoconstricted enough to maintain a BP. So now you need to improve the cardiac output. For that, you can add these agents, dobutamine, milrinone, or levosimendan. But before adding these agents, you should be sure that the BP is reasonably okay. Otherwise, this agent will cause hypotension. Now, septic shock, warm shock. So first will be, this is after boluses. So the first choice inotrope will be norepinephrine, which is your first choice pressure. Then I discussed with you, if you increase the dose of norepinephrine up to 0.2, the next agent to add will be vasopressin. We will be discussing these in the different case scenarios. Okay. So now if you find that it's a cardiogenic shock, obviously cardiogenic shock will be cold shock. You start with epinephrine, you try to improve the BP. So once the BP is improved and still the perfusion, so most of the time in cardiogenic shock, you start epinephrine, BP is improved, sometimes the perfusion also improves. But if suppose the perfusion is compromised and BP is good, then you add inodilators. So it's pretty simple, right? So we'll be discussing this in case scenarios. Now, again, a common doubt is whether we can use inotropy in peripheral line. So yes, you can well use adrenaline, dopamine, even noradrenaline in the peripheral line for short duration. Short duration means less than 24-hour duration. If you're anticipating more than that, then or anticipating more than 12 hours, then you will have to use central line. Otherwise, you can well manage this patient with peripheral line. But when you use peripheral line, you have to maintain at least double dilution. Okay. Some books say 5 times dilution and all, but double dilution. So here you mix weight into 0.15 milligram in 50 ml NS. So earlier we were mixing in weight into 0.15 in 25 ml NS, 1 ml will be 0.1. So here 1 ml will be 0.05 because it is double dilution. 2 ml per hour will be 0.1 mics per kg per minute. So, for example, classically nowadays we see a lot of these MISC patients. Their shock in those patients improve very rapidly. So, in those patients, you don't need to. We hardly in our patients. So, for 18 patients, only 2 patients we needed to put central lines. All other patients we are managed with peripheral line because rapid shock improves within 12 to 24 hours. So, in that patient with a wide bore cannula, you start double dilution of inotropy, even pressure in peripheral cannula. And you can get away with that. You can save the cost of the patient. Okay. Another importance is if you are even if you are sitting in a peripheral setup, and if you find a patient in shock, you give bolus obviously. Then you find the patient is still in shock. You want to transport the patient to a higher setup. So you have a peripheral IV cannula. You assess this whether it is a cold shock or a warm shock, and if it is a cold shock, just start adrenaline. Weight into 0.15 50 ml NS, 1 ml per hour, and before transporting the patient, this can improve your blood pressure, improve your perfusion, and it can be life-saving till the patient reaches a higher setup. So you can very well start inotrope through peripheral line, and you can use it for a shorter time, and the only provided the dilution is good. Okay. So starting inotropy before transporting a sick children is of paramount importance. Now we go back to our case scenario and we will be discussing the management here. So be ready with your chat box. So this was the first case what we discussed. Again, 8-month-old boy, cough cold for 2 days. Now presented with irritability, non-specific complaint, tachycardia 196, tachypnea 6. There is vasoconstricted or narrow pulse pressure shock, cold shock, peripheral pulse absent, hypoxemic. There were crepitations, muffled gallop rhythm, and all of you identified it as respiratory distress and hypotensive cardiogenic shock. Now here we go for the management. So what are the initial steps in management? Obviously, ABC, oxygen, 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 start oxygen, fluid bolus. It will be slow bolus, 5 to 10 ml per kg, isotonic saline, and you send blood for lab investigations. Okay. So after first bolus, 10 ml per kg bolus, you still find that heart rate is 180, BP is 70/40, 8-month-old child, periphery is still cold, pulses are feeble, there is no urine output, feeble cry, still hepatomegaly present. So the question is, what is your interpretation now and what you do now? So you can give your answer in the chat box.
One answer is add dobutamine.
Okay, we'll wait for a few more answers.
Epinephrine, add adrenaline. Epinephrine. You need to tell the interpretation as well, I think, right?
Okay, so very good. So we will be starting epinephrine. It is a hypotensive cold cardiogenic shock. So dobutamine we cannot add now because BP is 70/40, it's still in the hypotensive range or just maintaining the BP. If you start dobutamine in this patient, the BP will crash. Diastolic BP will fall, the patient will crash. So we have to start epinephrine. Okay. So meanwhile, the investigations also came. So the ionized calcium was 0.7, lactate was 3, SCVO2 was 60%, and there was acidosis. Base excess was minus 14.5, and SpO2 was 100% on O2 with NRM. Okay, so you started epinephrine rightly, as many of you rightly said. Okay, now what else we do is, you see this child is saturation is only 90% and child is tachypnic. So now we'll discuss regarding whether to intubate this patient mechanically ventilate, because intubation, mechanical ventilation, X-ray, then central line insertion, urinary catheterization. These are the further steps. Okay. So if you decide to intubate this patient, why you are, I will just tell, even after starting epinephrine low dose, the child's BP was not improving, child was tachycardic, child was tachypneic, and you decided to intubate this patient. So what are the precautions which we will take during intubation? So this I will tell. So you have to use rapid sequence intubation and avoid drugs causing hypotension like midazolam. So intubating a patient with myocarditis have to be done extremely careful, and you have to be prepared for the worst event. You have to be prepared for even cardiac arrest. Okay, so intubating any patient with shock is going to be tricky. That is more so with myocarditis because the patient is already having pulmonary edema. The patient will desaturate very fastly. So you have to be prepared. You have to start inotrope epinephrine first, then maintain a little level of BP, and then with all preparation, you should intubate this patient. Avoid midazolam here. Now, what are the benefits of intubation in myocarditis? And specifically, we have come early to intubation because this is myocarditis, cardiogenic shock. So in cardiogenic shock, you start inotropy, the patient is not improving, still in shock. Then we consider intubation. It is unlike the other shock. Here the intubation comes very early. So what are the benefits for intubation? Any at least 2 points? Please give your answers.
There are a few answers. Demand decrease, myocardial oxygen demand, adequate perfusion with improved oxygenation, reduce preload,
Very good,
decrease
very good.
cardiac work.
Very good. Most of the answers are correct. In fact, okay.
Another answer,
So
PEEP.
very good, very good. So most of them are correct. So in cardiogenic shock, there is a role for early intubation once it is inotrope, once it is catecholamine refractory, because one is to decrease the work of breathing. So you understand shock, it is based, we try to increase the oxygen supply and we have to decrease the demand. So 25 to 30% of our body demand is spent for our respiratory work of breathing. So once you take off that breathing, you paralyze the patient and take him on ventilator, the oxygen demand of the body comes down by 30%. So that is paramount importance. Second, reduce the oxygen demand of respiratory muscle. Then in cardiogenic shock specifically, once you give a PEEP, that will reduce the preload and also reduce the afterload, and hence when the preload decreases, what will happen is when preload decreases, the pulmonary edema component decreases, oxygenation become better. When the afterload decreases, the cardiac output, the ejection fraction might improve, and PEEP opens up the alveoli, improves the oxygenation. So these are the benefits of early intubation in myocarditis. Okay. So child intubated we were giving adrenaline, we continued that adrenaline, and you should have noticed here the ionized calcium was 0.7. So we should have corrected that, because in myocarditis, the calcium is of extreme importance. So we try to maintain calcium, ionized calcium level above 1.2. So calcium acts as an inotrope, especially in cardiogenic shock. Even in postoperative cardiogenic, postoperative low cardiac output syndrome, we even start calcium infusions. So calcium has to be corrected. Then again, you have to, so this for discussion sake of myocarditis, when you encounter a myocarditis patient, the correctable causes are hypocalcemia, hypovitaminosis D. So you can start vitamin D sachet after starting level, then hypothyroidism. You would send a TSH level also. Okay. So there was pulmonary edema with enlarged heart size. So now you proceed to a echo. So what information you want from echo in a patient with myocarditis? First episode, myocarditis. You can give your answers, 3 points, at least 2 points.
Cardiac output, ejection fraction.
Yeah, very good. What more?
ejection fraction.
One more point I want.
Any sign of LV dysfunction.
Dysfunction.
Okay, so obviously LV myocardial contractility or LV function, that is compromised, that we all know. We want to quantify it. Then we can look at the IVC status, whether the child is still volume responsive or not. Now the most important in a first episode myocarditis will be to rule out two conditions. There are two correctable conditions. One is coarctation of aorta or aortic stenosis. So when you look at first, when a patient is presenting with first episode myocarditis, you have to rule out coarctation of aorta and aortic stenosis, which could have been there and which could have precipitated the LV failure. Okay, so that is what I wanted to highlight here. Okay, so as you all, so this is a typical echo what we find in a viral myocarditis. You can see this is the left ventricle. It's a globular dilated. This is RV. This is LV. See the LV globular dilated, and there is global hypokinesia. Okay, this global, just keep the echo probe on the chest, and you find this kind of LV. It is typical of viral myocarditis. So there was LV dilated with generalized hypokinesia, biventricular dysfunction, and the IVC was non-collapsible in our patient. So we move forward. So this is, I just wanted to show you how to look at the IVC. This is the phased array probe we keep in the subcostal region, and just tilt towards the left side. You can see the IVC like this. Here the IVC is just full. There is no collapsibility or variability. This is a volume overloaded IVC or a full IVC. You cannot give more fluid to this patient. Now another patient, you see the IVC is collapsing. So IVC is collapsing during respiration. So this means, it means that this patient, you can give more fluids. Okay. So in our patient, IVC was full. So you started inotropy, you started epinephrine, and vitals after 1 hour was, again, child was having tachycardia 70/40. Now the central pulse are good, periphery is cold, CFT more than 4 seconds. So now the next step will be, we check the IVC. Already the myocardium is a severe dysfunction, and you cannot give more fluid. Give more fluid, more pulmonary edema, the patient will worsen. So the next step will be to increase the dose of inotropy. So rightly, the inotropy dose was increased to 0.3 mics, and you find after 1 hour that child continued to have tachycardia. So BP has improved a bit. Now it is 80/40 for 7-month-old, reasonably good BP. The peripheries are still cold with weak peripheral pulses, and child has started passing some urine. So what investigation extra will you order to assess tissue perfusion? So my question, I will make it more specific. What are the laboratory markers of tissue perfusion? Please give your answers.
One second.
Yeah, very good. I'm getting some answers. So
SVCO2.
Very good. So lactate is the most important will be lactate. I agree. Second will be SCVO2, and ABG again to just look at the base excess. The most important is lactate and SCVO2. So I wanted to clear this concept here. So what is SCVO2? So SCVO2 means, so earlier I mentioned, when your body, example, if your body gives, heart gives 100 oxygen to a tissue, the normal oxygen extraction ratio will be 25%, and 75 will be returned. So the normal SCVO2 will be 75%, or anything above 70% is okay. Okay. So if the SCVO2 falls less than 70%, it means that your heart was supplying less. So that is the cardiac, either the cardiac output is very low, or your tissue demand, the tissue, instead of taking 25, it was taking lot much, or the tissue demand was very high. So that is why the SCVO2 less than 70% means it is a kind of surrogate marker for low cardiac output or low tissue perfusion. Okay. So it indicates global tissue hypoxia, indirectly represents the cardiac output. So in cardiogenic shock, SCVO2 is very important, less than, we target SCVO2 of 70%. Okay. And it guides us for the treatment. So lactate, again, it is one of the most important tool nowadays. So lactate alone, you cannot use it for diagnostic purpose, but a lactate in a patient presenting with shock more than 1.5 is the cutoff what we take in children. Arterial lactate more than 1.5 indicate compromised perfusion, and it is a good prognostic marker. For example, your patient comes with shock, you find that the lactate is 5, and after 1 hour, if you find that the lactate is 3, it is a good sign that your patient, the shock is getting resolution. But if you find that the lactate is worsening or the lactate is still 5, it means that the patient is not improving, and you need to improve the perfusion better. So lactate clearance has got a prognostic value, and lactate normalization within 6 hours has shown to improve the mortality. So lactate is a very important tool. Now, what are the therapeutic endpoints of shock? This for any shock, what are the therapeutic endpoints? So the endpoint will be threshold heart rate, minimal acceptable MAP, a good urine output, warm peripheries, normal CRT, normal mentation, and improving acidosis and increasing lactates. So these are the therapeutic endpoints for any shock. And while you manage shock, your idea is to achieve these endpoints as soon as possible. So in our patient, his base excess was -8, CO2 was 63%, lactate was 3.1. Okay, so the child was having low SCVO2, increased lactate, and suggesting low cardiac output state. So our patient was adrenaline 0.3, BP 82/60, periphery still lactate is 3. So what is the next step? Give your answers.
Add inodilator. Add dobutamine.
So excellent.
Milrinone, Levosimendan.
Yeah, excellent. So now it is the time to add inodilator. So in this patient, now you can add dobutamine or milrinone. Now some units are more comfort. I am more comfortable with the dobutamine because milrinone causes more hypotension. And if you are comfortable with levosimendan, you can start that also. So now it's the time to add an inodilator. So we added inodilator and dobuta up to 10 mics per kg per minute. And after 1 hour, we found that the central pulses are good, peripheral pulse good, CRT has normalized, urine output has improved, lactate has normalized, SCVO2 has improved. So now we have attained the therapeutic endpoints of shock after epinephrine and after dobutamine 10 mics per kg per minute. And now you continue the supportive management. Okay. So now we go to the second case scenario. So again, this was the patient we discussed, fever, cough, respiratory distress, who had differential air entry, tachypnea, hypoxemia, improved on oxygen. Child was having severe tachycardia, brisk 68/30, BP, good central and peripheral pulse, warm patient. So his RBS was low, and his child had multiple pustules in legs. So it was straightforward. So all of you identified it as respiratory distress and warm hypotensive shock. Okay, so the initial management. So now you can tell what is the first approach. So first will be, we started oxygen 6 liters. First bolus, no doubt. So I wanted to highlight this. His RBS was 59. So you have to correct the hypoglycemia immediately. So okay, now coming to what next? You can give your answer. So we have to reassess the patient, right? So after any intervention in shock, whether it is bolus, whether it is starting inotrope, just continuing reassessing the patient. So the patient still tachycardia, bit improvement 154, CFT 2, patient 8 years, still hypotensive, wide pulse pressure, warm patient. So what next?
Noradrenaline, norepinephrine. 2 answers we have got. All answers are for noradrenaline.
Okay, so you are right in one way, but just before that, you should have assessed the fluid responsiveness again, because it's a septic patient. You have given only one bolus, so just ensure whether the patient is fluid responsive. So we looked at the IVC and see the IVC is collapsible. So you can give one more bolus, right? So I gave one more bolus and reassess. Again bolus, reassess the patient. So again the patient is tachycardic, BP 74/32, good central, good peripheral pulse, skin temperature warm, you reassess again. So now the IVC is full and clinically the child has developed a hepatomegaly. So now what? So now, as you answered before, now it's the time for noradrenaline. So you rightly started noradrenaline at 0.1 mic per kg per minute. The dilution, the preparation, everything we have discussed before. Okay, so the baseline investigations were sent side by side. So the child was having elevated TLC, anemia, lactate was 3, SCVO2 was 71%. So look at this, it's a septic shock patient, high cardiac output is SCVO2 was maintained. And look at the chest X-ray. In chest X-ray, you see that there is opacity in the right lung zone. And you do a focus point of care ultrasound chest. You found that there is a pleural fluid collection, and you can see these strands there, which indicates that it is probably a emphysema. Okay, so now you continued managing these patients. So what else? So what are the things which we have missed in last? One important part, I think somebody have mentioned antibiotics. So this is what I wanted to emphasize. So in such a septic patient, antibiotics is of paramount importance. The earliest you have to give antibiotics. So give ceftriaxone plus it's a emphysema, so you have to give staphylococcal coverage, give clindamycin or clox or vancomycin. Now, the other part you missed was PRBC because HB was 7.9. This is the resuscitation phase of shock. So during the resuscitation phase of shock, we aim HB of 10. After stabilization phase, HB of 7 is good enough. Okay. So we have to transfuse these are supportive measures, antibiotics, transfusion. Now respiratory support, you didn't mention, we just started oxygen alone, but the patient was very tachypneic. So we either you start HFNC or non-invasive BiPAP, or if further tachypneic, you can intubate also. Now all these measures were done, and after 45 minutes, this was his status, heart rate 145, again hypotensive, good central and peripheral pulse. So what next? So noradrenaline was hiked up to 0.3. Okay, 0.3, and again child was having warm shock.
One answer is drain.
Yeah. Okay, very good. So I will come to that. So this fellow who was managing, he didn't drain the patient. Okay, so he hiked noradrenaline. The patient was still warm. So increased dose. The next inotropy will be. Very good. So this becomes a catecholamine refractory shock. Okay, so once you start fluid boluses and the patient doesn't improve, it is fluid refractory shock. You start the first line inotropy, which will be either adrenaline or noradrenaline, and the patient does not respond to maximum dose, then it becomes catecholamine refractory shock. Okay, so in catecholamine refractory shock, we'll target the normal map, SCVO2 and cardiac index. So cardiac index 3.3 to 6 you can measure either using echo, or nowadays there are devices, bedside devices which give continuous cardiac output like USCOM, electrical impedance based measures and all. So what next? So now this is the ACCM algorithm. So this point we discussed. Fluid refractory. So I told we start inotropy, cold shock, start epinephrine, warm shock, start noradrenaline. So our patient was catecholamine resistant shock. Okay, so there are now few points what we need to remember in catecholamine resistance will be. One is regarding steroids. Okay, so earlier a few years back it was like if it is catecholamine resistant, you start stress dose hydrocortisone, which will be give a bolus of 5 mg per kg hydrocortisone and then start 50 milligram per meter square per day hydrocortisone. Okay, nowadays the more evidence is coming that you need not start steroid in all patients. You start steroid only in patients who have adrenal insufficiency, who are at risk of adrenal insufficiency, like the patient is already a diagnosed case of a decent disease, or if the patient is already has been steroid on steroid for a long time. In such patient, you give hydrocortisone, but most of the units still practice that if it is catecholamine resistant, we start steroids. We start hydrocortisone stress dose 50 mg per meter square per day. Okay, so our patient, he was warm shock. He was hypotensive, warm shock, SCVO2 more than 70 on norepinephrine. So the next step as per ACCM will be start vasopressin. Okay, so just as per algorithm, we did that. We started steroid. We rechecked fluid responsiveness. IVC was full. There was no scope for further fluids. His SCVO2 was good. Cardiac index was maintained. We added vasopressin. There was showed some transient improvement, and again after 1 hour, child had hypotension. So we checked the IVC again. The IVC is flat. The IVC is full. There is no scope for fluids. So why the patient is not improving, or what did we miss to do here? So the answer was given by one student already. So ICD. So we forgot to drain the pus collection. The pus collection was there. So so this patient is a refractory shock patient, means the patient is not improving by manipulation of inotropy. So despite inotropy, vasopressors, vasodilators, the patient is not improving. So in refractory shock, there are some things when the shock is refractory, you have to rule out. One thing is pericardial effusion. You have to look at the pericardial effusion, especially septic patient, they develop pericardial effusion later. You have to rule out pneumothorax. You have to rule out intra-abdominal hypertension, hypoadrenalism, ongoing fluid blood loss or uncorrected hypovolemia, inappropriate source control. So in our patient, this patient was having emphysema. We did not drain it. However, inotrope you give, the patient is not going to improve unless that septic foci is not removed. So this was detected later, and we inserted a ICD and drained 200 ml pus, and the patient improved gradually. Okay. Now we come to another case. Again, it's a non-case of Hodgkin lymphoma on chemotherapy, and child was a neutropenic child, presented with fever, decreased oral intake, vomiting, decreased urine output. So child was tachypneic. The room air saturation was 90% only. On oxygen it improved. Then child had tachycardia, prolonged CRT, hypotensive, narrow pulse pressure, central pulse was good. It was cold shock. Blood sugar was maintained. So first, the initial management will be again start oxygen and gave 20 ml per kg, and aggressively this the treating physician gave him 2 times bolus. So what inotrope? So again reassess the patient, tachycardia, still hypotensive. Both central pulse is good, peripheral pulse still poor. We checked the IVC and found that the IVC was full. So what to do now? What inotrope? Nabil, any answers? Nabil, am I audible?
Yes, sir.
Okay.
Noradrenaline,
Yeah.
adrenaline, and that all the answer.
Okay. Okay. So this is a cold shock, right? So this is patient is in cold shock, vasoconstricted shock, peripheral pulse is poor, cold shock. So in cold shock, first we gave boluses, right? So the first will be adrenaline. Okay, no doubt about that. First will be adrenaline. We want to improve the cardiac output first year, and we want a little vasodilatation initially. So antibiotics was given, electrolytes was normal. So epinephrine we gave 0.1 and increased up to 0.3. And just one question. So what will be the first choice of broad spectrum antibiotic in this patient? This is a neutropenic patient presenting with shock. So what will be your antibiotic choice? Please give your answer.
One answer is meropenem, 4th generation cephalosporin. No other answer.
Okay. So in in a neutropenic patient, so the first what we want to cover is Pseudomonas. We should not miss Pseudomonas. So you should be giving antibiotic with Pseudomonal coverage. So usually it is Cefoperazone sulbactam, which has Pseudomonal coverage plus amikacin is the first line agent. But if the patient is in shock, you can add vancomycin also. So you need not go directly to meropenem. At least Magnus, Cefoperazone sulbactam plus amikacin both cover Pseudomonas. This will be your first line antibiotic. If the patient is not improving, then only you go for peptides, meropenem, etc. Okay. If this patient has a already if this patient has an infected line, for example, an infected pig line, then you start, that becomes an indication to start vancomycin or a gram-positive coverage. You have to cover staph also. So this was out of this topic, just for discussion sake. So we started epinephrine 0.1, titrated up to 0.3. Now the patient is still in shock. 148 peripheries are cold. What will be your next line? Cold shock, started adrenaline, all source antibiotic, everything given, still in shock. Next, we checked the IVC. IVC is full. So it is catecholamine refractory, cold shock.
Adrenaline.
Yeah, so very good. So this is, I wanted to teach this algorithm here. So last case we were here. So this case we are low blood pressure, cold shock, on epinephrine already. So next will be add norepinephrine. At least we are trying to increase the BP, trying to increase the blood pressure. Okay. So in this patient, we started noradrenaline 0.1 to 0.3, still hypotensive. We started vasopressin, still hypotensive. So this becomes persistent catecholamine resistant shock or refractory shock. So in these cases, you have to rule out two more things. One is, again, you have to look for pericardial effusion, pneumothorax. Then intra-abdominal pressure, you have to maintain less than 12. And so this patient was managed with, so we did a 2D echo, we ruled out pericardial effusion, X-ray, there was no pneumothorax, even in chest USG, there was no pneumothorax. Intra-abdominal pressure was less 6, and there was no pus collection evident anywhere in the body. So the next only option would be ECMO. So in this patient, for a shock patient, we start veno arterial ECMO. So I just wanted to sensitize you regarding this. What if the shock is refractory to all? What if everything fails? So then next management will be ECMO. Okay. Now coming to the last case, fourth case scenario, again we discussed about a multi-system inflammatory syndrome case. Okay. All features of MISC. So in this patient, patient was taken to PICU. Patient, we know that this patient was having low ejection fraction, cardiomegaly, cold periphery, CRT 4 second, heart rate 130, BP 66/32. So what will be your first line of management? Next step.
ABC.
Obviously, obviously we look at ABC, start oxygen, rule out a correctable cause, hypoglycemia, everything we have looked at it. Next step. Okay, we gave fluid bolus because there was a cardiogenic shock. We gave only a 10 ml per kg bolus slowly over 15-20 minutes.
Then norepinephrine.
Okay. Okay. So again, adrenaline after small bolus. That answer one. Dr. Srishti has given one answer. That's the correct answer, right? So it is cold shock, right? Cold shock, CRT is 4 seconds. We know that there is cardiac dysfunction, there is cardiomegaly, there is pulmonary edema. So we won't start with noradrenaline. So in a patient with already low cardiac function, if you start noradrenaline, what will happen? The afterload will increase and cardiac function will decrease further, right? So we have to first improve the cardiac function. So we have to attain inotropy first. So you start adrenaline first, you attain, okay, you understand that. So if the same patient had been warm shock, if there is no cardiac dysfunction, then you could have started noradrenaline. But here it is cold peripheries, cold shock with a compromised cardiac function. The first line will be adrenaline. So patient was having cardiomegaly and the patient was having low, this is around moderate 30 to 35% EF, I can say. So we started adrenaline, again respiratory support, you start some respiratory support, high flow nasal cannula. So again in a cardiac dysfunction patient, even if you don't intubate, if you give some pressure, like HFNC give at 2 liter per kg, give a PEEP of around 4. or you start NIV. So that gives some people, that will help the heart. It will decrease the preload, decrease the afterload, improve the cardiac output. Okay. So initially you can try HFNC even in a myocarditis patient if the patient is not very sick. So we started ceftriaxone. So I want to there are two agents, IVIG and steroids. This is what I wanted to wanted from you. So in multisystem inflammatory syndrome, for the shock resolution, steroid is extremely important. Steroid, you start steroid pulse, IVIG, you can see magical improvement in the shock within 5-6 hours. The shock part BP improves and you are able to taper and stop inotrope within 12 hours or so. So this child improved rapidly. Okay, so you can see day 1 heart was like this. There was gross cardiomegaly. By day 6, the heart size normalized. There was no pulmonary edema. And echo, day 1, there was a minimal myocardial function. And by day 6, EF was completely normal. Okay, so this was the last case we discussed. I'll try to finish it as fast as was a 5-year-old metal coin injection, massive bleeding from esophagus, cold extremities. So this we gave crystalloid, colloid, etc. There was bleeding from the esophagus. So this case was a compensated hypovolemic shock. So this I just wanted to highlight one scenario of hypovolemia also. That is why. So when there is blood loss, in mild loss there will be tachycardia, moderate loss narrow pulse pressure, and severe loss cause hypotension. So hypotension means already you have lost 40% of the blood volume. So loss of consciousness is very late in hypovolemic shock. Okay. So if the patient is having blood hypotension, the patient's weight was 14 kg, the patient blood volume will be roughly, for bigger children, it will be 70 ml per kg. It was 1 liter is the blood volume. So we have, if there is hypotension, there has been 400 ml loss of blood volume, right? So if you arrange blood, you can replace it in a hypovolemic shock. Because of blood loss, blood for blood, the blood is ideal. But till you get blood, you can give crystalloids or colloids. But if you are giving crystalloids alone, you will need to give large volume. So you can use colloids in this scenario after the first or second bolus and arrange blood as soon as possible and give blood. So in this, this concept is called permissive hypotension. In such patients who was bleeding, don't start inotropy to attain very high BP. The target a very low normal BP or a just 5th centile BP, because if you target very high BP, the ongoing bleeding will persist. Okay. Now this is one terminology which I wanted to make you familiar with. This is massive transfusion protocol. So in trauma patients, when you have to replace the half volume in 4 hours or complete blood volume within 24 hours of blood loss, so you just not need to give PRBC alone. We have to give PRBC, FFP and platelet, even if the coagulation parameters are normal, even if the platelet count is normal, because if the patient has lost half blood volume, if you give PRBC alone, what will happen? There will be a dilution and there will be coagulation dysfunction and bleeding. Okay. So usually you calculate the total blood volume lost and give it as 1 unit PRBC, 1:1:1, that 1 PRBC, 1 FFP, 1 platelet. This is when there is massive blood loss, which is half blood volume in 4 hours. Okay, thank you. Now, Nabil, we can take up questions if any.
Thank you, Rauf sir, for that excellent session. I think we can take questions in the chat box, right?
The participants can unmute and ask also. Yes.
You can ask any questions, however silly it may be, absolutely no issue.
So one question is, how will we calculate SCVO2?
Okay, so very good. So SCVO2, so I mentioned already. So what is SCVO? So it is the, so our body supply from heart, the SpO2 in the arterial blood will be somewhere, for example, 100%, something like that. Now the tissue extracts something at the tissue level, and it is the remaining is returned back to the heart via the vein. Okay, so the SpO2 level in the central vein is what we call ScVO2. So ideally ScVO2 we should be measured from a catheter which is inserted in the pulmonary artery, which is not practically possible. So the best measure of ScVO2 will be you take a sample from the internal jugular vein, that is from the central line from the internal jugular vein, and look at the saturation in that. So that is a surrogate marker of ScVO2. That is how we look at ScVO2. Now, if you go on to go to higher level, there are some catheters which can be inserted to the through the internal jugular vein catheter, which can give you real-time values of ScVO2 also.
There is a few more questions.
Yeah.
One question is indication of ventilation in septic shock with maintained airway.
It's a very good question actually. So I will just go to the algorithm. Wait. Yes. So while we go through the algorithm, so we did the initial management of shock. Okay. And we determined fluid refractoriness by 15 minutes. ACCM says, but at least by 30 minutes. And we start inotropy from, if it is fluid refractory, we start inotropy, and by 1 hour we should be able to determine catecholamine resistance. That is, we start first line inotropy, adrenaline or noradrenaline, and go to the maximum dose of it, and if still the shock does not respond, then it is called catecholamine refractory shock. Now there are a few steps. Once it is fluid refractory shock, it is better you insert a central line if possible. Again, it depends. You can even manage by a peripheral line, and you may insert a arterial line also. Now, once the shock is catecholamine resistant, this is the point where you have to consider ventilation. So this is one, even after on one full dose of catecholamine, adrenaline or noradrenaline, if the patient is still not attained the therapeutic endpoint of shock, this is the time you have to consider ventilation, and more so if the patient has some lung issues also. For example, if the patient has pneumonia also, then there is no doubt about it. So even in a patient without pneumonia, if the patient reaches catecholamine resistant shock, you have to consider ventilation. Then it is not that mandatory that you have to intubate this patient. It depends upon a lot of scenario, but our experts say that early ventilation helps these patients. The mechanism mainly because it decreases, if you take off the work of breathing, the oxygen demand of the body decreases by 25 to 30%. So that will help the patient immensely. So this is the time you have to consider before starting. Again, you have to start starting second inotrope. That's the time you have to consider ventilation. Now in myocarditis, I told you early, you consider ventilation very early. Okay, when you start adrenaline and when you're going to the maximum dose, perfusion not attained, child is having pulmonary edema, you prepare for ventilation.
Can I go to the next question?
Yeah, sure.
There's another question. So the minimum dose of adrenaline to start for cold shock is 0.1, not 0.05. And the same person has another question. How to wean off inotropes once shock is corrected?
Yeah, both are very important questions. So adrenaline, no, you can start from with a dose of 0.05. Okay, it does have pharmacological activity at 0.05, and then you can wait for 10 to 20 minutes, 10 to 15 minutes, and then high to 0.1. So the minimum dose is 0.05. Okay. Now the second question is how to wean off inotrope. So this is little tricky. So weaning of inotrope will depend upon the clinical scenario. Okay. For example, in a patient, for example, now we were discussing about the multi-system inflammatory syndrome. So the patient rapidly improve. The endpoint is achieved within 6 to 8 hours. Then you feel that the BP is well maintained, perfusion is maintained. In such patients, you can rapidly come off the inotrope. Like, for example, the patient is on adrenaline or noradrenaline of 0.2, then you bring down it to 0.15. For example, it's going at 2 ml per hour. You make it 1.5 ml per hour. Wait for 15 minutes, or rather you can wait up to half an hour. Then you bring down further, like to 1 ml per hour. Then you can rapidly taper and stop. In this scenario, maybe within 2-3 hours. But now if the patient is a cardiogenic shock, example, typical viral myocarditis. So as all of you know, viral myocarditis takes at least 5 to 7 days to recover. So you have started adrenaline to this patient and the patient is well maintained on 0.1. In a viral myocarditis, I know that it is going to take time. So you should not try to rapidly wean off this. So that depends upon the clinical scenario. So you maintain on this inotropy, or if needed to hike and maintain on this inotropy for 3 to 4 days. And once you do echo, you find that the cardiac function has started improving. Then you come down on the inotrope gradually. You start diuretics also to decrease the preload. Then in this patient, the inotropy tapering will be like every 2-3 hours you bring down by 0.15 to 0.1. Wait for 3-4 hours very gradually. Again, in a septic patient, for example, a patient with staph septicemia, the very rapid septic shock, you started 2-3 inotropy. Then in such patients also, you know that it's going to take time, antibody is going to take time. Again, in such patients, the inotropy tapering will be very gradual. So what I mean to say is that the inotropy weaning off will depend upon the clinical scenario of the patient, the clinical improvement of the patient, and what you are dealing with. So every time it is to be done gradually, but in some cases when there is a rapid clinical improvement, you know that the disease process has reversed, you can bring down it fast. Okay, there is one more question.
One question is about vasoplegia
Yeah, one
concept,
question.
but the question is not clear.
Vasoplegia concept. Okay. Actually, I understand what the person is asking. So, what is vasoplegia? So, okay. So, this is cold shock, warm shock. So the simplest way of understanding cold shock, warm shock will be cold shock. The patient is cold, peripheries are cold, the CRT is very prolonged. It means that the patient is vasoconstricted. Warm shock means the patient is warm. The CRT is flushed. You find a very low diastolic BP. This means that it is a high cardiac output, vasodilated state. So cold shock means it is a vasoconstricted and the cardiac output can be low or normal. Okay. Now, so as I mentioned, typical warm shock patients you get to see only in most of the time in hospital septic shock only you get to see such patients, because all these patients after some point of time, after few hours, sepsis induced myocardial dysfunction happens and these patients also go to state of clinical cold shock. Now, if you find this patient come to you late after 6 hours, you find the peripheries are cold, the patient is mottled, the pulses are feeble, and you label it as cold shock. But here what I meant to say is that even with this cold shock, you clinically assess it as cold shock, but you insert an arterial BP and you find that its BP is 60/20. So what does this mean? So even if the cold shock is actually not vasoconstricted, he is having vasoplegia, but he is cold because his heart is also decompensated. So the cold shock alone cannot determine the patient is vasoconstricted or vasodilated. So this is a point I wanted to highlight. So this is often debated. You can, Dr. Sujitra Ranjit madam, she has worked a lot on this concept. Okay. So the clinical assessment, if you see this cold shock and you tell that the patient is vasoconstricted, you might get wrong because you insert arterial BP, you find low diastolic BP, with echo, you measure this systemic vascular resistance index and you find that the SVRI is very low, the patient is vasodilated, but clinically the patient is cold. So this mismatch can happen. So the better after SVRI, after measuring SVRI, after arterial BP, then only you can put this patient is also vasoplegic shock. So this is what I wanted to convey. This is a bit complicated topic, but I hope you understood this. So, but again, the management wise, once the patient is clinically cold shock, it means that his cardiac output is low. So the first is the treatment wise, it will be same. You start adrenaline first. Then what will happen to this patient when you start adrenaline will be his systolic BP start picking up. After you find that the diastolic BP will be low, then you will need to start noradrenaline also in this patient. Okay, that way this patient will be behaving. Any more questions? Dr. Nabil, any more question?
One more question is there actually. Can we go for that? Role of
Yeah, sure.
shock management, role of colloids. And one more question is mechanism of action of noradrenaline. Two questions are there.
Very good. Okay, just welcome to. Okay, so I'm sharing my email ID and WhatsApp number. For further queries, you can contact me personally also. I'm always welcome. Okay, so first one is role of colloids in shock management. Okay. So usually, as colloids are not the preferred agent in shock, there are few conditions where you can use colloid. So that conditions include, first is in dengue shock after 2 crystalloid boluses. In dengue shock, when the patient is leaky, you give first bolus will be crystalloid, second will be crystalloid, then third bolus you may consider colloid. Okay, that too artificial colloids are not very recommended now. 5% albumin as a colloid can be used in dengue shock. The other condition will be burns patient, where you can use colloids. Again, the basic pathology, when the patient is leaking, colloids tend to stay in the intravascular volume for a longer time. So in burns patient, dengue patient, after the initial crystalloid boluses, you may consider colloid boluses. Then what else? These are the main indications, the dengue and burns. Okay. And then already explained, if the patient is having blood loss and you are getting your blood is you are not able to arrange it as fast as possible, then also you may consider colloids just for the temporary purpose. Other was mechanism of action of noradrenaline, right? So noradrenaline, I already mentioned, it is a pure or predominant vasopressor. So the action is on alpha-1 receptors, so by which it causes intense systemic vasoconstriction. It increases both systolic BP and diastolic BP. There is a mild beta-1 action also. It has some inotropic action, which is very minimal, and that happens in between the dose above 0.1. There is some inotropic action, but it's predominantly a alpha-1 action, predominant vasopressin, predominantly act on the blood vessels. Any more questions?
There are no more questions in the chat box, and if there are no questions, we can conclude. Right?
Okay. So, yeah, I thank
there are
all
no
the
more
participants. Okay, and I mentioned I given my email ID and WhatsApp number. For any queries, always welcome. You can for any queries or clarification, you always welcome. Okay.
Okay, thank you, Dr. Rao, for this excellent class on behalf of IAP Kozhikode. I'm thanking you all, especially all the PGs and senior pediatricians and all who are attending this class. It was indeed very useful for the practical purpose, as well as it will be very useful for our DNB exams and all. There will be OSCE stations asking PALs. So I hope everyone liked this, and thank you, Dr. Rao, once again. Thank you very much.
Okay, thank you. I should thank IAP Kozhikode and Dr. Ajay, Dr. Nabil, everybody for giving me this opportunity.
I forgot to mention Dr. Sabik, who has hosted this meeting. Thank you, Dr. Sabik, also.
Yeah, from my side also, I thank Dr. Sabik.
Okay, then we can end the meeting. Right?
Yeah.
Sabik. Sabik. Sabik, end the meeting. Hello. Because തോന്നുന്നു